We're going to give people one more minute to log in, and then we'll get started. Hello, everyone. My name is Daisy Linares, and I will be your organizer today. Thank you for joining us. Please submit your questions and comments using the question panel, which can be found on the lower right-hand side. Any questions not answered today will receive a response via email. To receive a contact hour certificate, attendees must view the entire webinar and complete the evaluation. There will be a link to the evaluation that pops up at the end of this webinar. This webinar will be recorded and available for later use at a later date. You'll receive a follow-up email within 1 business day with a link to the recording and the evaluation. In order to receive a contact hour certificate, the evaluation must be completed after viewing the webinar recording. On completion of the evaluation, please allow 30 days to receive your certificate. For any technical issues, please email webinars@cjfhc.org. The PowerPoint will be available upon request, and there is no commercial support for this webinar, and none of the planners have anything to disclose. Now I'm going to pass you over to Lori Navin to introduce our speakers.
Good morning, everyone. Our first speaker is Dr. Deborah Heller, professor in the Department of Pathology, Immunology, and Laboratory Medicine at Rutgers, New Jersey Medical School in Newark, New Jersey. Dr. Heller is going to address what the stillbirth autopsy can tell us. Dr. Heller?
Good morning. Thank you very much for inviting me. I wanted to talk about what information the stillbirth autopsy can provide. Here we go. I want to talk about what kind of information the stillbirth autopsy can provide, how a stillbirth autopsy is different from an adult autopsy. I'd like to talk about how the pathologist looks at a stillborn in terms of the evaluation, and talk about some of the more common things that we find as causes of stillbirth. And I have no disclosures. There was a paper that came out. This was actually in the New York Times, but it came out of the Stillbirth Collaborative Research Network, which was a big multi-institutional network. And what they found was that the placenta could identify a cause of stillbirth in almost 65% of cases. The fetal autopsy can provide information in over 40%. And you can see the other numbers here. And the best information that you can get is a combination of the placenta and the fetal autopsy. What can the autopsy tell us? Well, it can tell us about birth defects, congenital anomalies. Assuming that we have a non-anomalous fetus, we can look for evidence of infection. We can see evidence of anemia. If there's hypoxia, growth restriction, sometimes we can get clues about metabolic disorders. It helps us figure out the reason we might have hydrops. Other things that we can find information on include the timing of the death, how remote from the delivery the demise occurred, and does any of this impact on future pregnancies, which is really important. So the workup of a stillbirth clinically, we advise, of course, the autopsy and the placental examination. If the mother does not want to consent for the autopsy, you don't need a consent for the placental exam, and I would advise that you send that to pathology in all cases. It would be good to do either cytogenetics, or now more and more we're seeing microarray, and a Kleihauer-Betke test to see if there's any fetal maternal hemorrhage. Other testing as listed can also be performed depending on the clinical scenario. So when we receive an autopsy, the first thing we look at is how macerated is the fetus, and this is part of how we correlate how long there was intrauterine retention after demise. Ideally, you want to perform x-rays and photographs, and you can freeze tissue if needed. And the whole point of this is that if you have really good documentation, it can always be evaluated at a later date, so that if it turns out to be something unusual or unfamiliar, consultation can be brought in as long as there is good documentation after the fact. Now, anomalies are very common, but some of them are very minor. And, you know, if you find an extra finger or a cleft lip, that doesn't mean that it's the cause of death. So why would an anomaly relate to a stillbirth? Well, you have to think of it in terms of a number of things. First of all is that there's evidence suggesting that what you've identified is associated with increased mortality. And an example of this would be XO or Turner syndrome, a process where you very rarely see it in live-borns. That would be something like triploidy, a process where you know that if the baby is live-born, there's going to be neonatal death, such as anencephaly, or lethal potential, meaning that it's incompatible with life, not just a minor anomaly. Again, just to mention, this is a book that's out of print, and if anybody ever finds one, please send it to me. But this is the title of the book, and the placenta is what provides a great deal of information. Okay, what can the placenta tell us? Well, it can give clues. It tends to give you processes rather than sentinel events in most cases. It can tell you if there was diffuse placental insufficiency, meaning that there was not enough supply to the baby. It can tell you if there were infections. If you have someone with minimal prenatal care and the baby and the placenta are large and the placenta looks immature, you have to think of diabetes. If you see a lot of intervillous thrombi, you have to think of fetal maternal hemorrhage. If you see fetal thrombi, you have to think of hypercoagulable states. And sometimes the pathologist can tell you if there was a cord accident or an abruption, not always. And there is now a whole group of immune-related issues that have a recurrence risk, and those are phthalitis of unknown etiology, chronic histiocytic intervillocytis, maternal floor infarction, and massive perivillous fibrin. And these four together are all probably in some form an immune response to the pregnancy, which is a foreign tissue, and is associated with stillbirth, growth restriction, and preterm labor, and they all have a very high recurrence rate. Okay, how does the stillbirth autopsy differ from an adult? Well, in an adult autopsy, you can either remove the organs in a block or you can remove them one at a time. You want to preferably remove the organs in a block in a stillbirth autopsy because you want to preserve the relationship of the organs and be familiar with the fetal anatomy and circulation, which is different than an adult, so that you can see if anything's anomalous. Remember that the fetal circulation is created to bypass the lungs. Because the placenta supplies all needs to the fetus, you don't really need to perfuse your lungs. And so the circulation tends to go from the right side to the left by a patent ductus arteriosus and a patent foramen ovale. And those are normal and very often seen in a stillbirth. We can help evaluate why a baby is small for gestational age. And of course, you have to have dates so that you can tell if it's premature versus just growth restricted. When we approach growth restriction or small babies, we have to think of it in terms of fetal causes, placental causes, and maternal causes. And fetal causes may be chromosomal, developmental, or infectious. Placenta can be a huge host of lesions that prevent the placenta from doing its job. And of course, a mother who has contributing medical factors may also lead to a small gestational age baby. A large for gestational age baby is diabetes until proven otherwise and should be sought. So what kind of specimens do we receive as pathologists? It's different in different states. The laws are different, but in New Jersey and at my hospital, we consider a fetus under 20 weeks as a surgical specimen that does not require a maternal consent, and we handle it that way, unless the mother objects. If we don't have good age, if there was no prenatal care or we don't know, we do it by foot length, and that's how we determine. Any fetus intact who is 20 weeks or greater, we consider that an autopsy, and we require consent of the family. We don't need it for the placenta. The dilatation and extractions, we like to receive a consent if they're 20 weeks or over, if it is possible. So there's a couple of important observations, and these are things that inexperienced pathologists sometimes have trouble with. One is not to mistake the gender, and that's because in the immature fetus, they look very similar, and you have to look behind the phallus to see if there is a vaginal canal or not, and not overcall every fetus as male. I always examine the gonads to make sure, because many times the mothers know what the gender was beforehand. The second thing is not to overcall low set ears, which I do see a lot. And you can't determine low set ears before 20 weeks, at which point you want to see a continuous straight line from where the ear attaches out to the outer canthus of the eye. Now, in terms of intrauterine retention, there were 3 papers that were written in the 90s. They are all by Genest and his colleagues. 2 of them are fetal and 1 of them is placental. The one that is fetal that has to do with gross features is this one. If you look at a fetus that has been demised for about 6 hours or more, the umbilical cord turns that sort of brownish, reddish purple. After that, a lot of the timing has to do with how much skin peeling there is, and you can sort of assess how long it has been present. There is also a paper on the microscopic changes that you may see after intrauterine retention, but a caveat to that is that the autopsy has to be done shortly after delivery. And then the third one is the placental changes. And as I said, the gross is the discoloration of the cord. And then the microscopic has to do with the obstruction of the vessels in the stem villi. And you start seeing this change at about 48 hours of intrauterine retention, and it's very widespread at 2 weeks. Okay, so if we don't have an anomalous fetus, what can we tell? If you have an acute hypoxic or anoxic event, such as an abruption or something right before delivery, there isn't that much to see. You can see petechia. You can see it on the face, the trunk, and over the limbs. You can see it over the thymus, over the pericardium and the pleura. You can also see clots around the testis if it's a male, and you can see subcapsular hematomas in the liver. On the other hand, if there's chronic hypoxia, you may see the features of asymmetrical growth restriction, where the brain is spared at the expense of the liver and the other organs. And you would have low weight by percentile. You can do a brain to liver ratio. You can look at a couple other things, but that's usually what I do. And there's a few microscopic changes, and they would go with severe growth restriction. If the hypoxia was present over a long period of time, you may have fetal response in the placenta and in the fetus, such as nucleated red cells in the circulation, fewer generations of glomeruli. And if you had low oligohydramnios, low amniotic fluid, you might even see pulmonary hypoplasia, but that would only be in very severe cases. You have to look at the umbilical cord, because cord abnormalities can predispose to umbilical cord accidents, and that would include single umbilical artery, abnormalities of length, abnormalities of cord insertion or strength, obstructing knots, thin cord, and abnormal twists of the cord. And they have found that hypercoiling is associated with stillbirth. Hypocoiling as well has bad outcome. So when is it a cord accident? A lot of times, again, the pathologist can only contribute to thinking that it may be a cause. If you have dilated vessels and thromboses in the cord, chorionic plate or stem villus vessels, that's the minimum criteria. And then in addition, if you have a regional distribution of avascular villi or stromal karyorrhexis, that's more confirmatory. Okay, again, we talked about malformations. It's very common. 3% of newborns may have one. A lot of times it's just cosmetic. It is a leading cause of infant mortality, and then you have to think about genetic causes and environmental causes. Just a couple of useful definitions. A malformation is something that was never formed normally to begin with. A deformation is something that was formed normally and then becomes compressed, as in amniotic bands or something of that nature. A syndrome is something that's a recognized group of anomalies thought to be causally related, but not caused by each other, whereas a sequence is like a domino effect, where there's one initiating factor, possibly a mechanical, that leads to everything else. And the most well-known of these is the Potter sequence, or the oligohydramnios sequence, where the lack of amniotic fluid leads to everything else you see with it, the clubbed feet, the compressed face, the pulmonary hypoplasia, and the amnion nodosum. Okay, so pulmonary hypoplasia is probably what causes death in most cases of the oligohydramnios sequence, because that kicks in before you have problems with lack of kidney function. And there are several ways that we can assess it. We can assess it by weights, we can assess it by how many generations of alveoli, and we can do it by, ratios, calculations. So there's more than one way for us to figure this out. Hydrops fetalis is common, and the pathologist can contribute to helping to figure out what the cause is. And it's basically either immune or non-immune. In the past, the immune causes were mostly Rh disease, but since we have ROGAM, you have to think of things like other blood groups. Cal or Duffy are among those. If it's non-immune, the differential is absolutely enormous, and the combination of the autopsy and the placenta can help you figure out what this is from. And I think that is it. Thank you very much.
Thank you very much, Dr. Heller. That was wonderful. I think we all have learned a lot about what an autopsy can do for stillbirth or fetal death. Good morning. Our next speaker is Dr. Carlos Benito. He's the chair of the Department of Obstetrics and Gynecology at St. Peter's University Hospital. He's also an associate professor at Rutgers Robert Wood Johnson Medical School and St. George's University Medical School. Dr. Benito will be discussing the management of stillbirth. Dr. Benito?
Okay, thank you for inviting me today to speak on the management of stillbirth. I'll be mentioning some of the things that Dr. Heller mentioned in her talk and expanding it from the point of view of obstetric management. So the outline for the talk today is we'll talk about some background features of stillbirth, risk factors for stillbirth, the management, recurrence of stillbirth, and timing of delivery. I have no financial disclosures. So in terms of background, stillbirth is one of the most common adverse pregnancy outcomes, more common than we think, complicated about 1 in 160 deliveries in the United States. There are approximately 25,000 stillbirths at 20 weeks or greater of gestation that are reported annually. The total number of births in the United States in 2017 was 3,855,500. The percent of low birth weight births was 8.3%, and the percent of preterm births was 9.9%. In 2004, the stillbirth rate in the United States was about 6.2 per thousand, which was down from 6.4 per thousand in 2002. Since 1990, the rate of early stillbirth between 20 and 27 weeks has remained stable. at approximately 3.2 per thousand births. The rate of stillbirth after 28 weeks or greater has decreased from 4.3 to 3.1 per thousand births. And what are the most commonly reported risk factors for stillbirth? Congenital anomalies, karyotypic or genetic abnormalities of the fetus or the baby, fetal growth restriction, placental abnormalities, maternal medical diseases such as diabetes, lupus, renal disease, and cholestasis of pregnancy, hypertensive disorders of pregnancy, which include preeclampsia, infections such as parvovirus, listeria, or streptococcal infection or syphilis, smoking, or multiple gestation. Now, because of how stillbirth is studied, there are multiple different protocols in which infants with stillbirth are evaluated and classified, which makes it difficult to put information together into large bodies of information. Another limitation is that fetal death certificates are filled out prior to the full postnatal evaluation being completed. Therefore, the cause of the infant succumbing in utero may not always be documented in the death certificate. And a significant proportion of stillbirths still remain unexplained, even though a thorough evaluation of the stillbirth has been completed. Estimate of maternal risk factors and risk for stillbirth with a background of 6.4 per thousand include the following. Chronic hypertension has a prevalence of about 6 to 10%, or 6 to 25 stillbirths per thousand, or an odds ratio of anywhere from 1.5 to 2.7. Diabetes treated with insulin has a prevalence of 2.4%. Renal disease less than 1%. If the mother has a previous stillbirth, her risk of having another stillbirth is about 1%. If the mother has had a previous growth restricted infant or a small for gestational age infant, it's about 6.7%. Smoking significantly contributes to the risk of stillbirth, about 10 to 20%. And if the mother uses medications, that may also be a cause of loss. So how do we manage mothers with stillbirth? And the key word here is being sensitive to the mother and the couple and the family who have suffered the stillbirth. If the infant has been given a name, the fetus and the infant should be referred to by name. And grief-stricken parents are often very reluctant to give consent for evaluation and autopsy examination, and some may have some religious or cultural objections. In this setting, it's very important for parents to be informed about the reasons for the autopsy, what types of procedures are done, and what the potential costs may be. And one of the ways that I explain the situation to the mother and the father and the family is that, as Dr. Heller described, is that these are surgical type incisions, and they're not the forming of the fetus or the infant. They're always concerned about causing damage to the fetus or the infant. And even though bereaved parents may not want that information initially, the healthcare providers should emphasize that these results may be an important part of the evaluation and may be useful for the patient and her family when they plan future pregnancies. Something that's often difficult to focus on for the family when they're so grief-stricken. If the family objects to a standard autopsy, they should be informed of other methods of evaluation, including the use of photographs of the infant, X-ray imaging of the infant, ultrasonography, magnetic resonance imaging or MRI of the infant, and tissue sampling. Blood and skin may be saved from the fetus to do genetic testing of the tissue from the fetus. And it's very important to do a thorough evaluation of the face, the hands, the feet, and the body to determine whether or not there is a genetic syndrome that had made the infant or the fetus pass away in utero. Now, what are the most essential components of evaluation for a fetal death or stillbirth? And the most important, as Dr. Heller had mentioned previously, was a fetal autopsy And it's very important that the placenta, the cord, and the membranes be evaluated. And as Dr. Heller had stated before, this does not require a consent form, and can often be very illuminating in terms of potential causes of loss. And tissues should be sent either from the fetus, from the placenta, or the umbilical cord for a karyotype evaluation or CGH array. Examination of placenta, either gross and microscopic examination, should be performed, and it is considered essential. Examination of the membranes, looking for evidence of infection, looking for evidence of oligohydramnios is very important. The umbilical cord may corroborate autopsy findings. There may be true tight knots in the umbilical cord, which lead to abnormal perfusion from the placenta to the fetus. And even if the family declines fetal autopsy, histologic study of the placenta is considered very acceptable, a non-disfiguring or malforming of the newborn. Fetal laboratory studies include karyotypic evaluation, meaning genetic testing of the genetic tissue. If chromosomal culture is unsuccessful, you can use fluorescent in situ hybridization, or what's called FISH, or you can send the tissue for a CGH array, which does not require live cells for studying. And chromosomal information is particularly important if the fetus displays any dysmorphic features or abnormalities of the face, hands, ears, and so forth. Whether or not the fetus is measuring smaller than what it should based on last menstrual period or prior ultrasound dating, if there are anomalies that are grossly seen of the fetus, if there's evidence of fetal hydrops or excessive fluid retention of the fetus, growth restriction. Fetal karyotype is also important if the parent carries a balanced chromosomal malarrangement, and either translocation or an inversion, or has a mosaic karyotype. And this can be studied through samples of amniotic fluid, portions of the umbilical cord sent for genetic testing, portions of fetal tissue, including skin, can be sent for genetic testing, and portions of the placenta can also be sent for genetic testing as well. The maternal evaluation begins with a very thorough maternal history that should be looking for known conditions or symptoms that may be suggestive and are associated with stillbirth. And these include exposure such as medications or viral infections. A family history and a 3-generation pedigree should be obtained to see if there's a family history of either stillbirth, in utero, intrauterine fetal demise, or neonatal death very soon after birth. Relevant original medical records can be obtained, and causes of stillbirth should be documented whenever possible. Gestational age by last menstrual period is very important. Maternal examinations, laboratory studies, ultrasound studies that were done throughout the pregnancy can be used to correlate physical findings of the fetus. Possible non-genetic causes such as infection, placental abruption, umbilical cord abnormalities should also be considered. Then laboratory evaluation for causes of fetal demise include a complete maternal blood cell count, or a CBC, Klein-Harvey-Becky, the most commonly underdiagnosed cause of intrauterine fetal demise, parvovirus IgG and IgM antibodies, and RPR. And syphilis is rapidly increasing in the US population. Lupus anticoagulant antibodies, anticardiolipin IgG and IgM antibodies, thyroid-stimulating hormone. Thrombophilias may be studied in special cases, and this should include a factor V line or prothrombin mutation, particularly when there are multiple infarctions of the placenta or in the setting of fetal growth restriction. Indirect Coombs and hemoglobin A1C in the cases where maternal diabetes may be suspected as an underlying cause of intrauterine fetal demise. Methods of delivery include the timing of delivery, after which the fetal death has occurred. And in the setting of fetal demise, there is no urgency to deliver the pregnancy, although most patients will desire a prompt delivery. But the timing in and of itself is not critical in terms of maternal harm. Coagulopathies associated with prolonged retention are very rare. In general, in the second trimester, patients may opt to have a dilatation and extraction of the fetus, and that can be offered where there's an experienced provider available. Patients should be canceled that dilatation and extraction may limit the efficacy of the autopsy for the detection of macroscopic fetal abnormalities and this morphology. Labor induction is appropriate at later gestational ages. If a second trimester dilatation and evacuation is unavailable, this may be performed based on patient preference. Now, always the biggest question is what's the risk of this happening again or recurrence counseling? And counseling can be hampered by inefficient information that's garnered through the prior evaluation for stillbirth. And in some cases, breast stillbirth may still be unexplained despite having a thorough evaluation. In patients in whom complete evaluation for previous stillbirth is not done, evaluation should be completed with parental permission, although the evaluation may be limited depending on what tissue and what testing is available. When specific risks are identified, such as antiphospholipid antibody syndrome or fetal placental hemorrhage or genetic issues, the risk of recurrence may be more quantifiable and measurable. In low-risk women with unexplained stillbirth, the risk of recurrence stillbirth after 20 weeks is estimated to be about 7.8 to 10.5 per thousand, with most of these occurring prior to 37 weeks gestation. The risk of recurrent stillbirth after 37 weeks is very low, about 1.8 per thousand. Women with a history of a live birth complicated by a preterm fetal growth restriction have an increased risk of stillbirth of about 21.8 per thousand in the subsequent pregnancy. So these women need to be watched much more closely. The rates of recurrent fetal loss are higher in women with medical complications such as diabetes or hypertension or obstetric problems with a significant recurrence risk such as placental abruption. Despite reassurances, these patients are likely to be very anxious and require special support during the subsequent pregnancy. Antepartum fetal surveillance or monitoring of the subsequent pregnancy for patients with a history of stillbirth includes a first trimester screen with nucleotranslucency, a maternal serum alpha-fetoprotein assessment at 16 weeks, a detailed fetal anatomical survey at 20 weeks looking for congenital anomalies which may increase the risk of a subsequent fetal demise in the current pregnancy, monitoring fetal growth on a Q4-week basis, fetal kit count starting at 28 weeks, at least twice daily, antepartum fetal testing, which is assessing fetal well-being starting at 32 to 34 weeks gestation, either once or twice weekly, depending on the clinical situation, and elective induction or delivery at 39 weeks gestation. Now, delivery may be brought up to 37 weeks in the setting of fetal lung maturity documentation via amniocentesis, depending on the clinical situation and the patient's desire. And this concludes my presentation for today. Thank you very much.
Thank you, Dr. Benito. Our next speaker is going to be Cheryl Dwyer.
Hi. Thank you, Dr. Heller and Dr. Benito, for explaining the value of autopsy, placenta examination, and post-loss evaluation. I am Cheryl Dwyer. I am a nurse consultant with Central Jersey Family Health Consortium and the coordinator for the Fetal Infant Mortality Review Program. I'd like to discuss now how to compassionately communicate with the grieving parents the importance of the post-loss evaluation to increase acceptance of autopsy. I have nothing to disclose. Typically, one of the first thoughts or questions parents have when informed of their baby's death is questioning why, what caused this, how can this happen, and also wondering if they caused the death. It is important to recognize and validate parents' concerns in the beginning, as this is the start of the communication regarding a post-loss evaluation. Being mindful that this is not the time to ask for consent for an autopsy, but an opportunity to acknowledge their questions and concerns and provide an overview of the tests that can be done. In addition to the parents' concerns, New Jersey's Autumn Joy Stillbirth Research and Dignity Act is implemented in the New Jersey Administrative Code, Title 8, Chapter 35, and within the regulations there are certain requirements related to autopsy and alternatives to autopsy for stillborn children that apply to all New Jersey healthcare facilities providing birthing services and newborn care services. Portions of the regulations delineate responsibility for physicians to address autopsy with the patient and other parents, and for the facilities to provide postmortem services for stillborn children. Physician responsibilities in detail include offering autopsy and alternatives, which are described in the definitions portion of the regulation. Also, the discussion is to include the significance the findings may have on future pregnancies, as well as the impact it could have for other families in the future. The definitions section of the regulations define alternatives to include a placenta examination. Also, that a consent form specific to stillbirth that includes a declination, and that the reports are sent to the Department of Health for data collection to be available to researchers. When communicating with grieving families who have received unexpected tragic news, remember the importance of allowing time for processing and informed consent regarding options. Sitting down in a chair at eye level allows for conversation to happen. When in a state of shock, as these families typically are, hearing this news, they will not hear everything you say. It will be important to repeat information, and in speaking with parents, the conversation should be broken up into multiple ones. So these are the factors influencing decisions that were identified in a study by Sherman et al. Entitled Understanding Mothers' Decision-Making Needs for Autopsy Consent After Stillbirth, Framework Analysis of a Large Survey, that was published in Birth 2018. It included 460 Australian and New Zealand mothers and analyzed responses to the multi-country online survey for stillbirth mothers. It modified a previous identified decision drivers model by Horry. Here they identified 4 major decision drivers and 2 decision aftermaths. As well as the decision drivers, it noted if it was given as a reason for autopsy or a reason against autopsy. Most had dual nature as a reason. Some of these included the preparedness to make decisions. It's the certain of action to take, or feeling overwhelmed or unable to take things in. And that affected both whether they decided on the autopsy or not. Parental responsibility was the obligation to determine what went wrong, consideration of needs of future children, desire to protect the baby from unnecessary harm, and acknowledgement of parenthood. Possible consequences were a better peace of mind, fear of blame for the outcome, and legacy or providing meaning. The role of the health professionals was supportive of autopsy, and that actually affected as a reason for having an autopsy. And then the decision aftermath was the poor communication of autopsy results and a decision that led to regret. Some that led to decisions solely against autopsy were a desire to protect the baby, fear of blame, and quality of communication that was unsupportive of autopsy. These are important topics to address when discussing autopsies with families. They also noted ways to create a supportive decision-making environment, and it requires providers to recognize that these are difficult decisions and they require support even after the decision, and that they can have long-lasting consequences. Also important to assess what the parents' thoughts are and where they are at this point, and tailor the discussion. You need to expect a wide range of views and elicit what is important to the parents at that time. Is it information for future pregnancies or the baby's legacy to help others? Avoid making assumptions, imposing values or opinions or decisions. Be mindful of tone, timing, and content. Allow parents to guide the level of details, and allowing them to make an informed, autonomous decision may minimize regret later. Acknowledge they are parents and they need to protect the baby from further harm. They don't want their baby to suffer anymore. Allow the parents time with their baby and to do parenting activities. Don't rush them with their baby. Acknowledge a feeling of self-blame and clarify concerns. Assure the parents that the baby will be treated with respect. Inform them how the procedure will take place and that they can still see their baby afterward. Prevent unnecessary distress arising from poor communication of results. Establish the timelines and how the results will be reported back to them. Many parents are surprised at the length of time the results take. Try to provide the results as you receive them. So this is a recently published study in prenatal diagnosis by Lewis et al. And it's the communication and support from the health professional is incredibly important. The qualitative study exploring the processes and practices that support parental decision-making about postmortem examination. When discussing postmortem examination, we must be sensitive to religious and cultural beliefs and laws that forbid autopsy. Important here is to notice the three different groups. So group one is not open to postmortem examination, and that would be in the case of a religious or cultural belief or personal belief. Group two would be consenting regardless of the concern. And group three has a process that requires support throughout, with the final step being consent. At any point in this process, they may decline an autopsy. We'll take a look at the steps. Is an initial approach of planting the seeds, which is not asking for consent, and it is the recommendation to have both parents present and at a time when they can listen. Second, providing the time and space we talked about before, and giving written material to reinforce what has been discussed and to allow them a different mode of communication. Phase 3 is more detailed discussion about the value of the postmortem exam, although it is not a guarantee, which needs to be discussed with the family. An individualized discussion to the family, offering consultation with religious leaders and reassuring them that the baby will be treated with respect. Phase 4 is formal consent. And note that the consent is not being obtained until this fourth phase. The reference to SANS Autopsy Consent is an organization in England that supports perinatal bereaved families. These steps allow the information to be processed and an informed decision to be made. To assist you in working with families experiencing a stillbirth or perinatal loss, there are many organizations that provide literature and professional support. Through a grant from the March of Dimes, Central Jersey Family Health Consortium, along with the other maternal child health consortia in the state, created a toolkit for stillbirth and perinatal loss. This toolkit is available on our website, and we have some hard copies available for providers in our region. Many national bereavement organizations exist and have literature for families, including information on autopsy and post-loss evaluation. ACOG Practice Bulletin 102 provides information for providers on management of stillbirth. Let's take a look at how to access the CJFHC Toolkit for Providers. To access the toolkit documents on our website, you would choose the Data, Resources, and Toolkit at the top banner, and then Stillbirth and Perinatal Loss. This will open a list of all the documents that are included. Some are provided for the healthcare provider only, as this one is, to provide hints for communicating with families. Other documents, such as this one, can be printed and given to the parents. This acknowledges their grief and introduces options they have, including detailing the potential post-loss evaluation, including autopsy and alternatives. We hope the information provided will assist you in feeling more knowledgeable and comfortable discussing a post-loss evaluation with families. Thank you for your time and dedication in helping families. It truly makes a difference.
Thank you, Cheryl. That was very informative. I'd like to thank our other speakers, Dr. Heller and Dr. Benito, for participating today. At this time, I'd like to remind you that in order to receive your contact hour certificate, you must complete the evaluation. There will be a link to the evaluation that comes up at the end of this webinar. This webinar is being recorded and it will be available for later use. You'll receive a link to this webinar along with the evaluation in the follow-up email within 1 business days. If you are viewing this as a recording, you are still able to receive a contact hour certificate. Please complete the evaluation that you should have received the link to along with the link for the recording. On completion of the evaluation, please allow 30 days to receive your certificate. The PowerPoint is available on request. Please email webinars@cjfhc.org in order to receive it. Thank you, everyone, for attending today.